Good morning, everybody. Thanks for having me here. I'm humbled to be present in a forum where there are lots of cutting-edge research going on, and my topic is very simple and clinical. We talked about liaison between clinical and other people, other personnel, and so mine is clinical. I'm a vascular surgeon, and my co-author is a family physician. Now, what is tinnitus? Tinnitus is a sensation of hearing ringing noise or buzzing, hissing, or other sounds in the ear. It can be continuous or intermittent. The tinnitus can be loud or soft, and it can be very debilitating for patients. Usually, tinnitus is associated with ear problems. As you can see, external ear problems in the external ear or any blocked external ear can then cause vibrations in the middle ear, and that can in turn lead to hearing noises. The sound is conducted from the external ear into the eardrum, which then vibrates every time there is a sound wave, and that is then conducted to the inner ear by the series of small bones, and then that in turn activates the cochlea, which is a spiral organ with very sensitive nerve endings. And then there is a cochlear nerve, which then conducts the activity into the brain. So tinnitus can be due to problems in any of these areas. So the causes of tinnitus, you can start from the brain. So acoustic neuroma is a tumor of the brain involving the hearing part of the brain and the cochlear nerve. That can cause, these are rare causes. So I'm just going by the order. Then ischemia, that is problems with blood supply to the brain. Involving strokes, etc., can cause this. Problems with the inner ear, these appear to be the commonest causes. So chronic exposure to loud noises, age-related hearing loss, and Meniere's disease, which is a very debilitating disease when people have it. It is associated with deafness and also hearing these loud noises. Changes in the middle ear bones can also cause tinnitus. Then outer ear, if there is any blockage in the canal. Temporomandibular joint disorders. Temporomandibular joint is the joint of the jaw. That can also cause problems. Tinnitus can occur from head injuries, neck injuries, head and neck tumors. High blood pressure. Sometimes if the blood pressure is very high, patients tend to hear the heartbeat or noise in the ear. Then turbulent blood flow due to any cause in the head and neck area can be heard as a noise. And there are many medications which can cause tinnitus. So we had a history, a patient, a 20-year-old male who presented to his family physician, who is my co-author, with initially sore throat symptoms. And on questioning, he also said that he was punched in the left side of the neck about 3 or 4 weeks prior to that. And then he woke up with a stiff neck. And over the course of the next few weeks, he started hearing a buzzing noise in his left ear. The noise was constant, and the examination revealed that there was no neurological deficit. when we examined the patient, a trill is something you hear with, you feel with your hand, a vibration, a sensation of vibrating in this area, in the posterior triangle of the neck, that is this area of the neck. And a machinery murmur. So a murmur is something you hear with a stethoscope, and a machinery murmur means it's a continuous murmur. As you know, the cardiac cycle is divided into systole and diastole, where the heart pumps and then relaxes. So this murmur is heard throughout the cycle. There are some other murmurs which are heard only in the systole. Then we went on to investigate, and the initial CT angiogram and duplex scan and the MRI did not reveal anything. So we knew there was something going on. However, the initial tests did not reveal anything. So we persisted and we did a specialized vascular duplex scan. I will show you the results. Now, the vertebral artery, which is the artery taking the blood to the back of the brain, the posterior part of the brain. And this is what we found when we duplex scanned the vertebral artery. I just spend a bit of time explaining this. Now, as you can see, the scan is color-coded. So the range is from -33 to +33 centimeter per second. So anything beyond this range will show in, these are ranges from red to blue. So anything that is beyond that range will show as this multiple colored kind of diagram. And you can see there is a lot of turbulence in the thing, and this is called color bleeding, where the color actually is seen beyond the vessel. That is an artifact because the blood is flowing very fast. Duplex scan consists of three things. One is the actual ultrasound image of the artery, and then the color image, and thirdly a spectral image. And this is from a Doppler wave, that is an ultrasound wave that is sent into the tissues, and the reflection comes back, and we can work out, there is a formula to work out what's going on in there. And as you can see, the blood is flowing very fast. I'll show you the normal waveform in a very short while, but you can see that we call this the peak systolic velocity, which is the velocity here. And this is 395 centimeter per second. And the end diastolic velocity, which is here, is 175 centimeter per second. This is very, very fast and turbulent flow. And as you can see, I will show you the next diagram where the normal waveform is. But you can see that there is filling of all these. That means there's a lot of turbulence. All these blood vessels are, the cells are going here and there everywhere, and they are reflecting the scan back. And you can see that all this area is filled, and there's a very high flow. This is more or less a normal waveform. This is how it should be. So as you can see, the peak systolic velocity, that's the peak here, should be less than about 60 or so. And the end diastolic velocity comes down to about mid-20s or even less. And you can see there is this black area, the radiolucent area, which means the waveform, the flow is very laminar, and there is no turbulence, and it's normal flow. I'll go back to the other one, and you can see all this area is filled, and it's very high flow. This velocity is 395 and 175. So this told us that there's something going on in the vertebral artery. Now, we then went on to look at the internal jugular vein, which is the vein, the main vein, bringing the blood back from the brain. And this showed that the velocity is 423 centimeter per second, and all this is, very high flow. This shouldn't be so. I will show you in the next slide. And you can see the color bleeding and the turbulent flow and everything. This is not a normal flow pattern for one of the larger veins. This is not it is a normal venous waveform in a what we call a central vein, the larger veins. This is not the internal jugular vein, but a subclavian vein. This is not the same patient. This is a different patient. But I just wanted to illustrate the difference. Here, in larger veins, you get flows up to about 50 centimeter per second. There's a fairly clean waveform. There's oscillation of the thing due to breathing and all that. So there is what we call phasicity in the flow. And if you compare this with the other one, it's all filled and it's very high flow and it's very turbulent. So we knew that there's something going on between the vertebral artery and the internal jugular vein. Then with this information, we repeated the MR angiogram, magnetic resonance angiogram, and that then revealed, confirmed there is a fistula. That's a connection between the vertebral artery and the jugular vein. I will just illustrate the normal blood flow to the brain. The brain is supplied by many arteries, so it's not easy to knock out the blood supply of the brain. So this is the aortic arch. So the heart will be below this, and then coming up here, the carotid artery on the right side, and then that divides into two, the internal carotid artery and the external carotid artery. The internal carotid artery is the main artery that brings the blood into the brain, and then along that there is another artery called the vertebral artery that comes from the subclavian artery, which is the artery going to the arm. So on each side there is a vertebral artery, and that brings the blood in the back of the neck, and it comes on and supplies the back of the brain, the posterior part of the brain. The internal carotid artery supplies the anterior part of the brain. And there is communication between these arteries at multiple levels. So even if one artery is blocked, usually another artery will take over and continue to supply the brain. At the base of the brain, all these arteries join up and form what is called a circle of Willis. Now, these are the vertebral arteries which are in the back of the neck. They come and they join together and form what is called the basilar artery. So it's right at the brain stem, and it supplies the brain stem. There are these branches going to the brain stem, and it then comes and becomes the posterior cerebral artery. The internal carotid artery, which comes in the front of the neck, comes and divides into what's called the anterior cerebral artery and the middle cerebral artery. This is the middle cerebral artery, and this is the anterior cerebral artery. And they join together with the artery called the anterior communicating artery. So as you can see, there is a circle, and if any of this is interrupted, the other arteries will take over normally. There are other levels of communication from the heart up to the brain. There are many levels of communication between these arteries. However, the circle is complete only in about 25 to 30% of the population. That means there are incomplete communication between the arteries of the two sides and the arteries of the front and the back of the brain. These are the common varieties, but I'm not going to go into details. And this is a very important consideration when you're treating any of the lesions in the brain, because if we treat this condition, this patient, we may have to sacrifice that particular artery. That means we have to make sure that there is enough blood coming from the other side and the front and everywhere. So these variations are important, and I will show you a picture. Like this is the complete circle, whereas it is incomplete in like here this artery is missing. So this is a normal patient, no symptoms, normal person, but this is a normal variation. Sometimes this part is missing, or this part. So these are all normal variations. These are very common. So as you can see, the front of the brain and the back of the brain, the blood supply may not communicate. Now, even the vertebral arteries, which are on the back of the brain, as we saw, I will just show you. The arteries on the two sides, they join up together and form what is called the basilar artery. So the inference that if one of these is blocked, the other will take over, right? But that is not always correct. In 50% of the normal people, the left vertebral artery is the dominant artery. That means the right vertebral artery is small. And if you sacrifice the left side, the patient may get a stroke. And in 25%, the right is dominant. And in the rest, there's equal dominance. So these are all important considerations we have before we embark on treatment. We have a patient here who has a communication between the vertebral artery and the internal jugular vein. And there is turbulent flow there. If we don't do anything, the patient may have a stroke, because wherever there is turbulent flow, the blood can clot, and small pieces of this can then embolize, go into the brain, and cause a stroke. On the other hand, if we don't treat and leave it, the lesion can become larger, and it can also bleed, and that can be a problem too. So this is a very difficult area, because when we treat, we have to decide whether we're going to sacrifice the artery or not. We have to be prepared to sacrifice, and the patient has to be aware that he may still end up with a stroke, although it is rare. So we referred the patient to our neuroradiologist, and they selectively catheterize the vertebral artery on the left side. When we inject contrast into the artery, it should go into the artery and go into the brain, and it should not immediately show the vein. The vein is filling up very early here. When we inject here, you can also see the vein. This is very abnormal, because if we do delayed pictures, the blood will, you can see the contrast medium in the brain, in the vein. However, if you see early filling of the vein, that means there is a communication between the artery and the vein. And as you can see, there is a communication in this area. Now, what are we going to do about this? Because when there's a communication between this and this, their options are either to knock out the artery, that is to stop the artery here and here before and after the communication. That necessarily will stop the flow into the brain from here, but also stop the flow into the arteriovenous fistula. However, if you are able to deploy what is called a covered stent, that is a stent which is covered with fabric. So the blood cannot flow out of that. See, if there's a stent here, then the blood cannot flow out of the artery into the vein. But the problem here is this is in a very tortuous area of the artery, and it is very difficult to deploy a covered stent in this area. There have been studies, and everybody will agree that this is a very difficult area to treat, and I will show you some results later. So we ended, or the neuroradiologist ended up coiling the artery before and after the communication, and after the thing we injected, they injected contrast into the right vertebral artery. This is the other side, and you can see that that is filling the brain. This is the and filling the left vertebral artery down to here, but then there's no flow here. So the treatment has been successful, and fortunately the patient did not have any stroke. This is the delayed pictures. So you saw earlier that the vein filled up immediately when there was a communication between the artery and the vein. Here the vein is filling up later, much later, and you can see that there is no communication between the artery and the vein. Now, this patient had a punch in this area and ended up having this arterial venous fistula, right? This could have been a lot worse. I just wanted to illustrate to you, show you a case which really shook the Australian nation. It happened a few months ago. Cricket is a game that is played, loved and played all over Australia and the Commonwealth. Those of you who are from the US may not know cricket, but it's like baseball. And this is the batsman. This is called he was Phil Hughes. It was his name, and he was hit. Although he was wearing a helmet, he was hit by the ball in this area of the neck. And unfortunately, this is exactly where our other patient was punched. Unfortunately for Phil Hughes, this is where he was hit, and this is where it stuck, right? So if you, I'll just illustrate you, what this picture is about. So the vertebra, this is the carotid artery. It's in the front of the neck. This is the vertebral artery. This is in the back of the neck, and it goes through, what's called the vertebral canal, which is many, holes in the vertebrae, the cervical vertebrae, and then finally comes out just before entering the skull. And normally, injury to the vertebral artery is associated with injuries to the neck, like a whiplash injury or somewhere where the artery is stretched and then released and you get injury here. Direct trauma to the vertebral artery used to be quite rare, but we have seen a few cases where there's punching in this area, and also from cricket and other games. Now, when this is the illustration, the vertebral artery comes off, the subclavian artery goes in the back of the neck through these holes between the vertebrae, and then the second cervical vertebrae, it comes out, and then the first one is called the atlas, the first vertebra, and it lies on the back of the atlas and then enters the brain or the skull. And this area is covered by dura mater, one of the coverings of the brain. And unfortunately for this cricketer, Phil Hughes, the injury was here, but the bleeding was inside this area, inside the brain. As you know, the skull is a rigid area, and there is no space. So when there's bleeding, necessarily the brain will be compressed. And unfortunately for this batsman, he died because they could not do anything. So I just wanted to show a little bit about the trauma to the vertebral artery. So this is Denver criteria. I'll give you the reference in the end. So anyone with blunt trauma, as you know, trauma to the arteries can be either due to some sharp object dividing the artery, or blunt trauma like a ball or a punch or a whiplash. And so they worked out why, when and where you should screen for these, because when somebody has had a head injury or something, and you don't always look for trauma to the arteries. So they have developed this criteria where, if there's a fracture in the cervical spine, or if there's an unexplained neurological deficit, or if there's a fracture in the cranium, in the base of the skull. This is Lefort fractures are fractures of the mandible. The different types. So certain types are associated with injury to the arteries. So there are these criteria where you should screen for injury to the artery. So you have to do a scan. Nowadays we do duplex scan, which is an ultrasound non-invasive scan, but you can do a CAT scan, CT angiogram to look for these. And they have graded these injuries into grade 1, which is irregularity in the vessel wall, but only the less than 25% of the diameter, and to grade 5, which is complete transection of the artery, which is what happened in that unfortunate incident where the cricketer died. In between, the vessel can be blocked, which may result in a stroke if there is no circulation from the other side or the front of the brain, which supplies that area of the brain. Pseudoaneurysm is when there is a breach in the arterial wall and there's bleeding outside, and then the blood will then go out and in and out and in. Again, that is something that may need treatment because it can then cause bleeding. Another extension of the pseudoaneurysm is when there is injury to the artery and the vein together. So there's communication between the two. So the walls of the artery and the vein are breached, and so the blood is flowing from the artery into the vein, and that can become a problem, like what this patient. So these are the references for these criteria, etc. This is where I come from. This is Australia, and we have a lot of sunny beaches. This is Gosford. And this is the waterfront. We get a lot of colorful birds in the back garden every day. Thank you. I will take questions. Sure.
I noticed on the angiogram or whatever, where
yes.
you had the blockage on the right side, but the left side fed into the full brain.
Is
blood flow, do you have a normal amount of blood flow going into the brain with one side, with one vertebral artery occluded?
Yeah.
And does the other one make up for that amount of blood flow?
Usually it does, but as we mentioned, in 50% of the patients, the left vertebral artery is the dominant vertebral artery. That means the right side is smaller. It may or may not take over if the left vertebral artery is knocked out. Similarly, in 25%, the right vertebral artery is the dominant artery. That means the left vertebral artery is smaller. And if that patient is unfortunate to have some problem in the right vertebral artery, then there's a chance that the left vertebral artery may not be able to take over. But having said that, usually, if one artery goes, there is some kind of supply from the other side or the front of the brain. I'll just go back a few slides to show you the brain has a lot of rich collateral circulation. So I go even further back. Now, see, this is the aortic arch, okay? And there are multiple levels of communication. So there will be communication between this is called the subclavian artery that supplies the arm, but there is communication between that artery and this artery, which is the carotid artery. At multiple levels, there are branches of this, and they go and they join up together. And then at this level, the carotid artery divides into external and internal carotid arteries. The internal carotid artery goes into the brain, but the external carotid artery supplies the muscles of the face and eyelid and all that. However, in the orbit, around the eye, and there are few areas where they do join up. So there is a collateral circulation between those two. And then coming further up into the brain, this is at the base of the brain. So the brain stem will be here in this area, right? This is right at the base of the brain. And there is what's called the circle of Willis. So the arteries coming from the back of the brain, which are the two vertebral arteries joining up, and the arteries coming from the front of the neck, which is the internal carotid artery coming right in the front of the neck. They all join up together and form a circle. So there is collateral circulation there between the front of the brain and the back of the brain and between the two sides. But this is only in 30% of the patients or people. In the rest, there will be something missing, some area of this circle missing. So we can't always be sure that if you knock out one side, the other side will take over. But we see a lot of patients who have blocked internal carotid artery, which is the main artery to the front of the brain, and they have survived and without a stroke. So it's very hard to predict who will have stroke and who will not. But we have to be aware of all these considerations when we do this, when we treat this. Sure. Yes.
Do you think the tinnitus was caused centrally or peripherally by the hypoxia?
That's a very good question, because centrally also, if you have ischemia to the brain, in that particular area of the brain, then you can have tinnitus. But in this case, we could feel the vibration. We could hear the vibration. I think he was hearing this vibration. So I think it's peripheral from the arteriovenous fistula. But very good question. All right. Thank you very much.